Good morning. Thanks for the opportunity to be here today. Really important to think about how we better control symptoms. The diseases that we're talking about today have a huge impact on lives of the people themselves who experience it and the people who love them. And so we need to think about this from the point of view both of people with these illnesses together with their caregivers. As we think about that, I saw in the news a couple of weeks ago that Tim Winton's book, Breath, is now being turned into a movie, and they're actually filming it in Denmark, Western Australia. And for those of you who've read it, there are a couple of racy bits in it that you might have wanted to skip or read twice, I don't know. But he describes catching a wave which actually was running earlier this year. Comes every 10 years or so, and there's a break off the Western Australian coast, which, if you can catch it, is a really exciting experience, they told me, as a surfer. And if you fall off your board while trying to catch it, it's an even more exciting experience. And he describes being held at the bottom of the ocean because he fell off his board the first time he did it. And literally being held at the bottom of the ocean by this wave, unable to do anything except lie there, thinking that he'd breathed his last. And so he wrote, "It's funny, you never think much about breathing until it's all you ever think about." And I'm sure there are lots of people in this room today for whom that is the lived experience. So I want to talk about particularly interstitial lung disease broadly today. We can tease out different types of underlying causes for that, but at the end of the day, the symptom burden is very similar. And really what I want to focus on today is that there are lots of very practical, evidence-based things we can do to improve symptom control in this setting. And so with that in mind, just a couple of things, the symptom burden and some of the things that we can do there, and then to focus on breathlessness particularly, and ensure that we're paying attention to that challenge. So what is breathlessness? There are all sorts of theories about breathlessness, but at the end of the day, it's a subjective symptom. If someone says, "I'm breathless," they're breathless, okay? And we actually have very poor correlation between some of the things that your doctor will measure regularly, your lung function or some of the changes that we see on scans, and your subjective sensation of what's actually happening. At the end of the day, it's a mismatch. It's a mismatch between the body's desire to breathe and the body's ability to respond to that and to actually satisfy the body in that setting. Breathlessness is invisible across our community. And so one of the things that we did was go to people independently of their health service utilisation. So not through their doctor, not through their practice nurse, not through their hospital appointments, just in the community. Randomly on a Saturday morning, knocked on people's doors and said, "You got any breathlessness?" Pretty much. And it depends who was knocking on the door, I suppose. But at the end of the day, what we see is that 1 in 11 people across our community are breathless a fair bit of the time. But 1% of the population, 1 in 100 people, are really quite breathless all of the time. And 1 in 300 people in our community, 75,000 Australians, are housebound because of their breathlessness. It's totally invisible to much of the community, and we've got to change that. You and I have a responsibility to get a message out there that breathlessness is really disabling, it's frequently encountered, and it's causing a huge burden across our community on a day-to-day basis. The next thing is we're not good as health professionals in recognising breathlessness. This was a study that was done in Melbourne, and in this study they asked young doctors, and we pick on young doctors, we shouldn't, because no one else was any better in the system. We asked them, are the people you're looking after breathless? And if so, how severe is that breathlessness? And they got it right in about 50% of the time. So it's invisible. And one of the things that you and I can do is make it more visible. One of the things is to impress on your doctor as you see them, if you have breathlessness, the impact that this is having on your life. Because as a researcher, one of the challenges I'm faced with is you ask people, are you breathless? They go, no. Not right now. What can you do without getting breathless? Well, you know, I can look after myself. I can still make a meal. I can still... What have you given up because you're breathless? That's the real question, and that's what you need to be telling your doctors. What have I given up because I can't do it because of breathlessness? If it's playing with the grandkids, then tell them. If it's getting out and playing a round of golf, tell them. We've got to make it more visible. So what are the symptom burdens? This was a study done in the United Kingdom by Jason Boland and his team from Hull York Medical School. Pain is actually a really big issue. Of course, we talk about breathlessness, but pain's an issue. Fatigue, feeling absolutely worn out. Not only worn out, but importantly worn out where rest doesn't necessarily fix that. Breathlessness. What are the things you can't do because you're breathless? And then rates of anxiety and depression that are above the rates of the community more broadly. And one of our challenges, again, your challenge and mine, is that we may well have clinicians go, well, of course you're going to be anxious, you're breathless. No, that's not okay. This is anxiety that is out of proportion to the breathlessness. And they feed each other, no doubt about it. But we've got to address each of them, and we've got to address them proactively. I'm also a clinician. I look after people with advanced illnesses, a wide range of advanced illnesses. And one of the things that people reflect on to me often is that they become socially isolated. They can't get out as much, be it breathlessness, weakness, tiredness. But more importantly, people stop coming to see them. That's a huge, huge burden. Suddenly their world shrinks. And again, as a community, we're not good at that. We're not good at supporting people through tough times. So if we look at people with interstitial lung disease, all of them, and compare them to people with advanced cancer, what's the picture that comes out? So people with interstitial lung disease in general were older. They were more likely to be male, and we've seen that in data presented upstairs this morning. Breathlessness was likely to be a much, much bigger issue. Anxiety was likely to be more profound. Certainly less pain, but still more than 1 in 2 people who said pain is a lived experience that affects my life on a day-to-day basis. 1 in 2 people with interstitial lung disease. So we need to acknowledge that pain and we need to treat it. There are good treatments for this that we can put in place that are well tolerated and genuinely change quality of life as a result. What about that anxiety and depression? Well, interestingly, here is where we saw some correlation with some of the things that you'll have done with your doctors. 6-minute walk tests or some of your respiratory function tests actually sit really closely with changes in anxiety and depression. And so as we think about that, we're also struck by the fact that as we have a few more birthdays in this world, we kind of collect a few more illnesses along the way. And so that also has an impact on anxiety and depression in this setting. So what do we know about this? We're just going to look at a small study. It was just 45 people. And depression was related directly to the severity of breathlessness, to the severity of pain, to the impact on sleep. Now, you know, I'm a medico. In my young days, I was up doing horrible shifts, 36-hour shifts. And these days, if I get woken more than once when I'm on call at 2 a.m, the next day is just lousy. Who of us functions really well the next day if we've had a broken night's sleep? And yet insomnia is a really big issue in what we're talking about here. And again, I, together with my colleagues, spend far too little time in making sure that people get a good night's sleep. Because a good night's sleep changes the way we see the next day, changes the way we function the next day. So I'd like to spend the rest of the time on breathlessness today, and I want to spend it on breathlessness because it can be treated so much more effectively than it is at the moment. That we can relieve a great deal of breathlessness safely and effectively and really improve people's quality of life. So if breathlessness is getting in your way, in the way of you doing the things you want to, then the next quarter of an hour is for you. Firstly, I need to be honest and upfront. We're not talking about getting rid of breathlessness. We're talking about reducing breathlessness. And so many of you will have been asked over the years to fill out a visual analog scale, 0 to 100 millimeters. No breathlessness, worst imaginable breathlessness, or worst experienced breathlessness. For people themselves with bad breathlessness, how much do we need to shift that in order for them to say, I'm actually feeling better? My breathlessness hasn't gone away, but I'm feeling better. And it's as small an amount as 5.5 millimeters on a 100 millimeter scale. For people to say, I actually feel a bit better. Because most of us don't run at 100 the whole time. Most of us run probably around 45 to 50. And so a 5.5 millimeter reduction makes a big difference in that setting. A really big difference would be 18 millimeters. And we've seen some treatments that come pretty close to doing that. Safely, predictably, effectively. So when we think about this, we've got national and international statements now that have changed rapidly over the last 10 years. Here's the American College of Chest Physicians. Breathlessness that persists at rest or with minimal activity and is distressful despite optimal therapy of the advanced lung or heart disease should be treated. In 1999, they shied away from that. Isn't it great to see that by 2010, they'd made that progress? And so we've got this really nice Canadian model, and the three stripes here in yellow, what we have is, let's get the underlying disease as good as it can be. You've got some lung disease, let's make sure we're treating that effectively. If you've got some heart disease as well, let's make sure we've got that fine-tuned. If you've got a bit of anemia, let's make sure we've got that fine-tuned. The middle rung in green is really asking us to think about all of those non-medication related things that we can do. How do you breathe? Can we help you breathe more effectively? There's some things that can change the mechanics of breathing for you. For example, for some people, a walking frame actually changes the mechanics of how the lung works and can help tremendously. Some of you will have had some breathing exercises from physiotherapists. And finally, in the blue, there will be some medications that for some people will provide safe, predictable, and effective benefit in this setting. So as we look to the evidence, pulmonary rehabilitation is really going to be incredibly important. There are some other things that have been tested, but they're all pretty marginal. And so again, with some of these, we've got some interesting medications, including, as you'll see, even thalidomide, which is making a resurgence in this space to see if we can improve breathlessness. So some interesting work going on in order to understand how we can improve things. What about improving symptoms? Oxygen is on this list, and for some people oxygen is indicated and really helps. For other people, they don't qualify for long-term home oxygen, And there is evidence, and we're doing some interesting work with colleagues in the United Kingdom, of just a handheld battery fan. One of my favourite photos, and I'm sorry I don't have it here this morning, is someone who was in one of our clinical studies. And he had an army shirt on, and you know, they've got 2 pockets. So what do you put in both pockets? Handheld battery fan. And that's how he kind of went through his days, and he loved it. He had cut back tremendously on his puffers, and whenever he was going to get short of breath or got short of breath, one of these came out. So we're doing a study at the moment to look at that benefit, but I think for a lot of people it's going to provide a fantastic way of reducing breathlessness. $2 at the $2 shop. Replace the batteries occasionally. Hopefully don't chop off any of the grandkids' fingers, and you'll have a lot of fun. Seriously, all of the evidence points to the fact that it is providing real benefit for people in that space. And so we've got things like walking aids and breathing training which can provide some real benefit. Here we are to the fans, directed to the face or to the leg, randomised. Doesn't sound terribly scientific, but it's actually interesting to see that it generates very different responses. And there was a significant difference between those treatments in reducing breathlessness in that space. They also looked at it compared to acupressure, and there's no doubt that the people who were randomised to get a fan used it for a longer period of time, for months, rather than acupressure, where, as you'll see on the next slide, people generally gave up, so that only 1 in 5 of those people were using it at 2 months, whereas 1 in 2 people were still using their fan. So it's not for everyone, but some people were deriving benefit just from a handheld battery-operated fan. And we need to think about those people who are most likely to benefit from that, and to match those people with that particular therapy. Thomas Sydenham was called the English Hippocrates. He looks very noble there, doesn't he? Most of the paintings of the 17th century made people look pretty noble. Of all the remedies it has pleased Almighty God to give man to relieve his suffering, none is so universal and so efficacious as opium. Now, who can argue with the English Hippocrates? I, for one, this morning am not going to argue with the English Hippocrates. In fact, I'm going to show you evidence that as we've got smarter over the last couple of decades, we now deliver this in very different ways to the ways it's been delivered before. One of my colleagues, Don Mahler, worked in New Hampshire, retired last year, but did a really nice study. He did a study where he asked people, in this case with emphysema, to get on a treadmill. And then he gave them a couple of injections, 1 each time they came back to the treadmill. The first time they just had normal saline, or they had a medication which we use in emergencies to actually reverse the effects of medications like morphine. These were people who were not on morphine. So what we're studying is the body's own morphine-like substances. Okay? What happened? The day that you were randomized to just get the normal saline, you did pretty well. The day you had the medication that blocked the body's own morphine-like substances, you could exercise as much, but you felt much, much more breathless. So the body's own morphine-like substances actually help us cope with breathlessness on a day-to-day basis. And so we've just published a study that looks at 16 studies that brings together this, in this case for people again with emphysema. But what we see in this is that absolutely all but one of those studies favours the use of low-dose, regular, sustained-release morphine for the relief of breathlessness. What we're seeing here is you can see the 0 down the centre of that graph. If it's on this side, it favours morphine. If it's on that side, it favours placebo or sugar pills or normal saline. And what we see is that each of these points, with the exception of one, favours the use of, in this case, low-dose sustained-release morphine. And the overall estimate says that there's a very real benefit in this setting. We looked at that also in terms of people taking this in the real world. And so we adjusted their dose week on week until they got some benefit. And if they got benefit, we then worked with them as they took it. And we followed them for up to 22 months over that period of time. For every 1.5 people that you treated, one person got benefit. Now, who's on a medication here for cholesterol? Yeah, I thought that might be the case. Australia's #1 drug prescribed. How many people need to take their medication for cholesterol to stop one heart attack 5 years down the track? Anyone want to start the bidding? Is it 10 people need to take it for 5 years to stop one heart attack?
I think it'd be quite a few more.
A few more? I've got a few more from the gentleman in the front row. Any advance on that, ladies and gentlemen? 80? Lots of people, yeah. Okay. It's actually at least a couple of hundred people for 5 years to stop one heart attack. Okay? It may be as high as 400 or 450 people. Here we're talking about, for every 1.6 people you start, one of them is going to benefit. They're pretty good odds. Because a lot of us are going to be taking medications that we will never know whether they directly benefited us, because we just know that at a population level they have some benefit. This is a benefit that you hopefully will be able to feel directly as a result of, for those of you who benefit. I just want to say that when you do get a benefit, it's really quite dramatic. So these were people who'd been on medication but hadn't really been getting any response. We changed the dose here, so we increased the dose again, and two things happened. Firstly, they got a really immediate response. So within the first 24 hours, they got a reduction in their breathlessness. But interestingly, while still taking the medication, the magnitude of that reduction actually doubled over the next 6 days. So by 7 days, the benefit that they'd got was double what they experienced in that first 24 hours. And so we know that people will benefit, that we need to adjust the medication in this setting to get to the right dose, and having done that, it will make a big difference. What are the things that help us understand the response to breathlessness for something like sustained release low dose morphine once a day as a capsule? Well, higher baseline breathlessness. The more breathless you are, the more likely you are to respond. And also, interestingly, younger age. And I think that's probably because people are trying to be more mobile and push themselves a little bit harder, but I don't have the final answer for that. And then we looked at this to see if there are any genetic predictors. And interestingly, it looks as though we also have a genetic predictor. We're going to have to follow this up in future research. And some of you may eventually participate in some of that research. But it's going to be really important to understand people who are going to benefit, people who are not going to benefit, and importantly, anyone who is only going to experience harms. So at the end of the day, is it safe? This is a study from Sweden that one of my colleagues published last year. And what we asked was, if you are taking regular low dose, and I stress low dose, sustained release morphine, what does it look like? Well, most importantly, what we see is that if you're taking low dose regular morphine, no change in hospitalizations, and absolutely no change in mortality. So the good news is that at 30 milligrams or less per 24 hours, in a large study, we're seeing no signal of problems in this patient population. What about our general practitioners and our specialists? I'm delighted to say that the last time I spoke at a meeting like this, the majority of respiratory physicians were using this medication to help with breathlessness. But a study from Canada asked general practitioners, family physicians, how are you prescribing? And they said, well, we don't really, not for this, because we're worried about a few things. We haven't done it, because we weren't trained. This is new since we were trained. No one's helped us understand how to do it, and importantly, we're worried that people, the authorities are going to come and knock on our door and say, why are you prescribing morphine in this setting? If you look at specialist physicians, so respiratory physicians, they said exactly the same thing. So again, we've got a challenge to get the message out there that there are things that we can do here and that we can make a difference. In conclusion, I just want to look at oxygen for a moment. Oxygen's something that's really easy to start and often really difficult to cease. And so we looked at oxygen. We've looked at it in a number of settings. This is a study that took 18 studies from around the world and put it all together and said, does oxygen help with breathlessness? Oxygen can help with life expectancy. Oxygen can help with oxygenation, but does it actually help with breathlessness? And the interesting thing is in people with emphysema, again, I know that's not today's topic, but this is the closest we can get from the evidence base we have, actually derive symptomatic benefit. They felt less breathless when compared to air pumped at the same rate. Now that was a radical finding, and a lot of people had a lot of challenges in us publishing that. And again, you've seen a forest plot a few minutes ago. Down here is 0. Anything to the left of it favours oxygen for the relief of breathlessness, and anything to the right of it favours air pumped at the same rate, 2 litres per minute through nasal prongs. All of the red dots sit either on or to the left of that line. And here again is our summary analysis, which suggests that there's symptomatic benefit in that place. But oxygen, as many of you know far better than I, can be incredibly burdensome. In a big study we did, we asked people about it, and we had people say, look, despite the fact I feel less breathless, it is such a pain to have to put up with oxygen. Through to other people who said, don't mind. It's given me some symptomatic benefit, I really like it. And I think that tells us that we are all individuals and that we have to tailor things like oxygen therapy to the individual person. So at the end of the day, in terms of symptom control, we have good evidence that we can relieve breathlessness for many people in this setting. And that in doing that, we can change day-to-day lives. The thing I haven't spent time on this morning, and I'm happy to talk about later, will be how we better support caregivers in this setting. I don't think there is a more powerless place in the whole world than watching someone you love who can't breathe. And so we need to find better ways to support caregivers. We need to prepare caregivers for their role. We need to support them during that time. And we need to support them in really understanding the great work that they do and celebrating that work, because we do far too little of that. Thank you.